Good call.
There we go.
I told you, I need that on the checklist, man. I forgot that all 3 times so far, I think.
Yeah.
Good job. All right. So welcome everybody to the Business of Healthcare Blab. Shahid Shah will be joining us again here today. And, just a quick overview. I'm Don. I am the product manager at Zen PRM out of Buffalo, New York. And we started the Business of Healthcare community basically to have a conversation around the practical day-to-day operational things that need to happen in healthcare, and not just kind of yell at everybody and tell them that they need to innovate. Let's help them do so. Let's identify the things that are slowing things down, and let's take the approach of what can we do about it? Instead of complaining about how things ought to be, let's look at it and say, okay, here's the situation we're dealing with. What's in our control, what's not, and when it's not in our control, what can we do to just align our businesses to it, and then hopefully get running smoothly and be able to do some innovation. So that's the premise of these conversations. And Shahid's been gracious enough to join us for a bunch of this and help us move it along. I appreciate that. So with that, you want to give a quick intro?
Sure. Thanks. And I love this conversation because as you and I have chatted offline a number of times, a lot of people complain and we scream and we talk about all the things that we don't know how to do. But in a $3+ trillion industry, nobody can do everything that we want to do. And therefore, if we don't participate and we don't do the innovation that we think is necessary, it just won't happen. I mean, there's so much going on in the space, so much uncertainty. I just came yesterday from the National Association of ACOs, the Accountable Care Organizations. Payment reform and all of the other things that are coming down the pike are going to be difficult. So it's going to take people like us. My background is in architecture and engineering of complex systems. And my formal training is in how to do proper R&D projects so that they come through a successful fruition. And it's hard in many industries, but near impossible in healthcare, given all of the different problems associated with the incentives alignment and the fact that the customer doesn't end up always paying for your product and all kinds of stuff. So looking forward to this conversation. I'm excited about the fact that we're going to talk about incentive alignment and a couple of other topics around intermediation, which is what I think is the biggest challenge for most developers because they don't understand how to innovate with this level of intermediation that happens.
Yeah, no, that's an awesome segue to the first thing I want to talk about too. And that backs us up to the conversation from last week's tweet chat was all around that, was all about intermediation and its impact on the system. It's an area that I've been loosely aware of, but I've been digging into quite a bit in the last couple of weeks. And it's fascinating and somewhat jarring. And, in the last couple of weeks, I'm really kind of coming around to the idea that most of the problems that we face today are actually a direct result of us working around that intermediation. And I'd like to get your thoughts on that to start out. Do you agree with that statement? What impact does intermediation have on the way that this business works?
Yeah, I totally agree with it. And in fact, it's one of the earliest conversations that I have with developers who say, well, how do I get into healthcare? What do I do? Why is it so hard? And I'm going to go old school and put up a little chart here. And I'm happy to share this chart with you guys as if anybody wants a copy of this, let me know. I'll forward this out, tweet it out later. Basically, it's one of the slides that I use in my little classes that I do on healthcare innovation. And what you'll see is that there is a complex web of how dollars flow. And so basically, if you look here, there are patients on one end, and then there are funders on the other end. So let me just bring this a little bit close. So the intermediation right now is you have patients, which are usually the people who are going to get our services, but then they go through a whole bunch of steps in the middle. And so those whole bunch of steps in the middle are starting here, for example, the care providers. We're very commonly using care providers in the middle. Care providers are then connected to the care institutions, followed then by the payer, the intermediaries, and then lastly, the funding providers. So let me walk you guys through this. Imagine you're trying to build a solution that's going to be used by a patient, but is going to be in the middle, going to be installed at an imaging center. Well, for that imaging center to buy something from you that a patient will then use, they have to make sure that they're going to be funded. Where is that funding going to come from? It's going to come from a funding institution, usually either the government or an employer or somebody on this side of the equation. If you can't follow a pathway from here into this area going all the way to the patient, it's not going to work. So this intermediation problem that we have is the core issue of why is it so hard to find money for the things that we need. And I brought up the Accountable Care Organization Association yesterday because accountable care and payment reform is one of the first times when we can say that the intermediation matters less. It still matters, but it matters less because we're taking what's known as either we're taking upside risk or downside risk, or we're sharing risk amongst a group of providers. So, for example, if I make a technology that is very, very helpful to patients, say that it's a patient engagement tool of some sort. Well, the patient engagement tool in a fee-for-service model has very little value unless that engagement tool saves time or money or provides top-line revenue growth for a care provider who is dealing directly with the patient. So we often almost always say that, hey, you should use my technology. It'll make your life easier. Well, that's not always true if there's no way to pay for it. So when you look at accountable care organizations, when you look at payment reform, what they're doing is to say, why don't you take risk on these patients? Whatever money you save, you get to keep, and some bonuses on top of as well. And therefore, any technology becomes valuable. So when we normally walk into a physician's office and say, hey, buy this iPhone or buy this telephone, et cetera, they don't need to necessarily worry that much about reimbursement because it's a fixed cost, a fixed asset in their environment because of the job that they're doing as far as care provisions. But once it becomes per patient, if it's an EHR, if it's a patient engagement tool, anything else, you have to help as the innovator figure out how is that technology going to be deployed? How is it going to be paid for? And because of this intermediation, we know that patients will pay some small portions, but it's employers and government that send the money. So where is the money going to come from for any technology becomes the core reason why it might fail. And the other reason that it might fail often deals with the fact that once you've solved intermediation, then you have to solve all of the other issues, which is workflows and integration and all the other things that we as innovators often forget is if I can't align my tool's workflow with the tool workflow that you're expecting done, you're not going to use it. You're going to say, hey, this is interesting, but it doesn't really fit in my environment. And so there's often people who wonder, well, why is it that some technologies, the uptake is very quick in medicine, like things like med tech or devices, lab equipment. Some of these things are fairly quick on the uptake because they don't make massive shifts to workflow. IT systems, unfortunately, by their very nature, shift workflows, reduce workflows for some people, increase them for others. So the number one problem we have is through intermediation of care, who's paying for the innovation? And the number two problem we have is once we find out who's going to pay for it, can we integrate it in a way that it's going to be used? I think those are our fundamental things that we could discuss that for weeks on end and still not have direct answers to those questions.
Sure. And so, you're coming at this when you're talking about a lot from the standpoint of a business trying to get their solution into there and how to, how to convince somebody to take the risk on them. So in a sense, like looking at the ACOs or other like groups that get together like that, they're getting together to share risk with treating the patients. But in a sense, it creates a risk sharing for these tools then too, because if I'm an individual provider taking on a new tool and interrupting my workflow and taking all that risk on it by myself is probably less palatable than kind of doing it as a group and maybe having some shared resources and like shared IT resources and shared management resources to kind of drive all of that.
That's exactly right. Yeah. And the other way to think about it is that in any B2B environment, let's say you're selling a financial services piece of hardware, let's say, a credit card swiping machine to a pizza shop owner. Well, when you go sell that credit card swiping machine to a pizza shop owner, the pitch you're going to make to them is, hey, you'll be able to take money from your customers faster. They'll like it more. And as soon as you swipe it, at the end of the day, I will deposit that money into your bank account, right? Pretty straightforward. And even then, it's hard. I'm not saying this is an easy sale. But look at that sale versus the sale that we often make in healthcare. We say, buy this technology, and maybe months later, after you've readjusted your workflows and taught your patients how to use something, and your admin people have learned how to bill for it, then maybe at some point in the future, you might be able to connect up and get the benefits, right? So the distance between the sale of the thing, of the innovation itself, and how long it takes to get the return on that investment is long and arduous. And as long as that's the case, we're going to have problems. So in the case of accountable care, payment reform model, what Medicare and commercial ACOs and others are trying to do is to say, why don't you guys just figure out the best way to take care of this? I'm not gonna tell you how to do one code here and one code there and what to do with this patient versus that patient. I'm going to give you 1,000 patients. You take care of them, and whatever money you save, and through innovation, through administration management, a reduction in medical loss ratios, whatever you want to do, at the end of the day, once you save money, I'll let you keep portions of that money in addition to bonuses. Now, when I go to that kind of institution and sell them whatever my innovation happens to be, I can make a direct business-to-business connection and not have to explain to them how they might get reimbursed in the future. That's really, really tricky. And when you look at innovators today, whether you're inside of a hospital, inside a physician practice, at a payer, or at a third-party startup company, we all have to deal with this. Mm-hmm. If I put something in, who's paying for it? Is it coming through reimbursement, a direct reimbursement, an indirect reimbursement, which is, again, that intermediation? Is it coming directly from a patient? So those technologies that you can get money from directly from a patient and not have to deal with intermediaries, indirect or direct reimbursement, that'll work because you can make the business case hopefully pretty quickly. Tough business, but it will get easier as payment reform aligns our incentives better across the ecosystem.
Okay. So when you're advising startups or groups trying to innovate in this manner, do you tell them to kind of focus on those ACOs, focus on the groups that are already taking on risk and doing the new payment models, and kind of steer them away from the existing fee-for-service stuff? Or are there techniques for dealing with, I guess, the traditional intermediation, where the problem's not quite solved for you yet by one of these programs? So there are techniques that you have to go in and deal with it in that scenario.
Yeah, that's a great question. I mean, ACOs are like a shiny new object, and many of us are chasing them. But just at yesterday's conference, this was NACOS, the National Association of ACOs. There were 48 vendors, about 500 people there. So in these 48 vendors, you had analytics companies, patient engagement companies, nutrition companies, pretty much anybody that would want to sell even to traditional organizations. They're making the bet and the thesis that these ACOs will be able to make decisions faster and employ these technologies more quickly, but it's not actually a winning argument because during the day, the one word that we heard most often, which scares most business people, is the word uncertainty. Uncertainty around what the ACO program will be. Uncertainty around, is it a one-way risk model or a two-way risk model? Uncertainty around, will the technologies that have been built for a fee-for-service model work in an accountable care model? Will accountable care organizations be around 2 or 3 or 4 years from now? Some organizations that actually the ACO program is slowing down. So I don't recommend startups unless you have a very precise and well-defined jobs to be done model that has elaborated very well what an ACO would be. Going after ACOs as a shiny new object is not something that I recommend. What I do recommend is looking at the traditional models, because that's where the trillions of dollars are. In the ACO market, you're still looking at low billions, not trillions just yet. So stick to where you're in hundreds of billions of dollars and make the solutions as tiny and easy to explain as possible. Like, for example, EHR integration, big problem. There aren't that many companies providing top to bottom full stack integration services. So when you look at services, full stack kind of services, is instead of going to someone and saying, let me give you a technology and you figure out how to use it and install it, let me look at the problems that you have and I'll take away an entire vertical segment of your problem. Just give that to me and I'll handle it top to bottom. That's a great way for a startup to come in because it forces them to learn the business. That's where I would say, so I wouldn't go and say, look at ACOs as a as an immediate revenue opportunity unless you know that market really well.
Got it. So part of the conversation that we've been having last week and then into this week in the tweet chat too is like taking a step back from the very specific, like talking about getting a technology into one of these places or into the healthcare system in general, how to innovate, and talking about how we got here in the first place. So the idea of intermediation, kind of separating the consumer from the consumer, the patient, taking the consumer out of them basically, and just having them be the patient. Somebody else is buying, somebody else is paying, and there's a lot of what seems to my point of view is negativity that happens as a result of that. That's where the incentives conversation came from today. So because we're separating those, the natural kind of free market flow doesn't happen, which forces us into creating incentives to try to simulate some of that. And my question for you is, as you know, right now there's different models being tried, and high deductible health plans and all these other things. Is this ever something that you envision changing, or is this one of those things kind of that we step back and we say, this intermediation is just going to exist, and it's going to exist largely like it does today for a long time? So let's just figure out how to best operate within it. Or is there something over the course of payment reform, the next 5-10 years, where the overall healthcare system starts to look and behave a lot differently?
Yeah, we're seeing a lot of behavior change from the payment reform that has already started. For example, the accountable care organizations, which 5 years ago didn't exist at all, yet today are doing hundreds of millions, if not billions of dollars worth of business. I think the simple answer is, at least until 2020, 2025, the majority of the way that the fee-for-service intermediated model works is going to remain. We're going to be chomping at the edges. Now, what that basically means is that for the next few years, there are some advanced personalities, think advanced groups like physician-led ACOs versus hospital-led ACOs versus what are called the super ACOs. They're doing business a little differently. So physician-run organizations, for example, physician-led guys can say, okay, I'll take care of an entire population, reduce utilization, and because my overhead and my fixed costs are lower, reducing utilization and replacing that utilization with other ways of making money, wellness programs, prevention programs, et cetera, is perfectly reasonable for physician-led ACOs. But if you look at hospital-led ACOs, these guys have very high fixed cost infrastructure, and they can't just reduce utilization. They have to make money off of their assets and their infrastructures by bringing people in and using that infrastructure. Like if you don't fill beds, you're not going to be able to make your ends meet at the end of the month, because those beds cost money and those rooms cost money. So we just looking at it as an ACO. They're both accountable care organizations. They both care about their patients, but because of their fixed cost infrastructure that was built in a fee-for-service world, they can't adapt to the ACOs as quickly in each one of these. So when you look at payment reform coming down the pike, any payment reform which says you must lower utilization in a world in which fixed cost assets remain at their cost can't work. It's an untenable situation. All that's going to happen is hospitals will run out of money, they're going to close down, et cetera. What you can do is to do what are these larger accountable care organizations, often referred to as super ACOs, which are kind of like very, very tiny health plans that will probably grow up to be health plans in the future. They can start to say, look, if I have enough hospitals and if I have enough physician providers, if I have enough people in my group, I don't worry that much that lower utilization will mean elimination of significant amounts of revenue that I need to manage fixed costs. At scale, at actuarial scale, not tiny scales like a couple thousand people, but we're talking about hundreds of thousands, multiple communities, multiple cities, then you can start to say that our fee-for-service models can start to change with new MIPS, new MACRA. There's all kinds of these acronyms that are coming out from the CMMI, which is the innovation group over at Medicare. But I think you've got at least 3 to 5 years, if not more than that, of fixed cost infrastructure, which still has to be paid back, which still has to run. So I don't see that any startups who are hoping for payment reform as their big moonshot could succeed in the next 3 to 5 years. By
Sure.
2020, 2025, as some of this older legacy cost starts to go out, maybe there might be a change.
Got it. Okay. That's so you're talking there about alignment at a community level and around these hospitals so that they can continue to be supported. So that's a good segue into a topic that came up today on the tweet chat was how, that's one of the things you hear all the time is, well, we need to align our incentives. Align our incentives, everything's going to be great. But you don't hear a lot of people explaining what that means or how that's possible. So that's one of the things we talked about today. And we didn't make any progress, I'd say. We don't have an answer. Actually, Dave Themicky here threw up a question and, was asking is the alignment really understanding this path through the intermediation and, trying to shorten that path as much as possible? And Dave, chime in if I'm misinterpreting your question here that you typed in. But, do those things go together? Is there a way to align providers, payers, the patients and everybody who all kind of have their own goals and are all being incented in different ways to do different things? How do we align them? Is that possible?
It's absolutely possible. And the way that you can think of it as possible, so much of this intermediation that we have is regulatory and statutory infrastructure. So statutory just means an act of Congress. Regulatory means that the executive branch could use what the act of Congress was in order to establish these approaches. So, for example, the shared savings program from Medicare is an act of Congress that says, find out ways, to CMS, go find out ways on how people can work together and share and do shared savings. Then these things like ACOs or other models are created by regulatory requirements that say, okay, if you guys band together, we'll give you this bonus and we'll pay you a little extra here, et cetera. So there's all kinds of techniques. So this alignment, and David's asking a great question, which is, what do we mean by alignment? What is the path? So if you look back at this diagram, which again, I'm happy to share later on with you guys, this complexity comes because we assume, let's say that I'm just selling something to the patient. If I'm just selling something to the patient, and don't think about how the patient is connected to the provider who's connected to the institutions, who is then connected to the funding sources, et cetera, that means that I'm being lazy as an innovator and not thinking it through. So one great way to do alignment is you force the alignment by doing what's referred to as a full stack service. So a great way to see what a full stack service is, Uber is a full stack service, a taxi cab is an unaligned single shot service. So with somebody like Uber, they went through. Now, if you think about the number of technologies associated, right? You've got mobile apps, you've got GPS, you've got logistics, you've got management of human resources. They pull everything together. So when I go to Uber, I say, I would like to get somewhere. And they make the rest of it happen. I just come to my phone and I say, I want to go somewhere. And they have connected up the entire supply chain to make sure that a car will arrive at the time that they say, and it will get me to my destination. A taxi cab is slightly different, right? I jump outside and I say, I want a taxi. And then once I get into a taxi, I tell the guy where to go. So you have both models. They're both successful. Like the taxi cab model has been working for decades, and it's been pretty successful. But the one reason why the Uber example as a full stack company makes sense is if you started to say to yourself in healthcare, where are the incentives misaligned? And can I connect the dots here and then offer an entire service to a health insurer? Like, for example, if you said, well, there's a bunch of these problems that I want to solve. Am I solving it for one party, meaning the provider or the care institution, like a physician or a care institution or a payer? Or am I looking across the various different stakeholders in this group, like payers and healthcare providers and the healthcare institutions that they work in and the patients? So when you wish for alignment from the outside, that's never going to happen. That's the lazy innovator's approach, is to say, oh, if only all of this laws would change and if only all of this stuff would change, then I would be successful. Well, you can't wait for all of that. You have to be willing to bend a few rules, not break laws, but break the models that are in there today. So when we say that incentives are misaligned, there are two ways of saying that. One is the lazy approach that says, it's misaligned, there's nothing I can do, I'm going to do the best that I can. The second approach is, let's go see what is the misalignment, and can we connect enough dots so that the technology that we create can be used as a service. Like, right, and when you go to Uber or Airbnb, you don't say, I want a hotel room or a something like that. You say, I want a place to stay. I need to find a home in a particular city. Now, the number of connections that these guys had to make is pretty big, right? They have to connect through all of these. So let's look at a real life example of no-shows or delayed appointments at an imaging center. So this is a big problem where at a let's say at a dialysis center or an X-ray where they take X-rays or MRIs, you need to get people to those facilities. In order to get people to those facilities, you could help by saying, okay, well, I'll help somebody with scheduling. So I give them a scheduling app, or I might help them with a patient engagement app, which points people to the scheduling saying you need to come in at a particular time, like a text message, etc. If you're just selling text messaging, or you're just selling scheduling, or you're just selling Uber, any one of these things shows you that with misalignments in incentives, the solutions are going to be really hard to sell. So what's the answer here? The answer is you step back and say, what is the actual problem that these guys have? Well, in a world of fixed cost assets, a la a dialysis machine, if a patient misses a 2-hour slot on a dialysis machine, that's $2,000 worth of cost. So what should we do? Maybe we should offer a solution top to bottom that will help know who the patient is, schedule them, get them there, and then get them out of there as a full stack solution that removes all of the incentives problems, right? Now, it forces you to be much more innovative and think through the problems. But this is what the big boys are doing. The big boys are sitting there and thinking of the complexity. They're seeing what are the jobs that I actually need done at my customers, and not giving them little solution here, a tiny little app there, or hoping that they're going to use an API. These are complex, multi-billion-dollar problems, and they require smart people to do smart things. And the misalignment of incentives is a general, it's a real and valid problem, but for an innovator, that's an excuse. The innovator says, how do I connect everybody together to do those incentive alignments?
Yeah, I love that approach. And that's, I mean, obviously that fits with the theme of what we're trying to accomplish here with the HCBiz conversation in general. And what's also pretty cool about it when you look at it from that standpoint is while there's misalignment, the government's going to try to fix that misalignment. And insofar as the private sector can come forward and solve these little problems, we could basically take those away. We take those out of Congress' hands, and it's almost like a way to. It's our best way of simulating the free market without, having with the intermediaries still existing. So, I always kind of take that serenity prayer approach to everything. And it's like, well, intermediation's not going away. Certainly, even by 2025, if we've made big progress in payment reform, there's still going to be intermediation. That's going to exist. So that's not something that we should sit and whine about. That's, what can we do? And the way that you just laid it out there was beautiful. So thank you for that. And I hope that's got everybody thinking a little bit.
Yeah, and one way to just think about that as a summary is, instead of thinking, what technology can I leave on somebody's doorstep and hope that they figure it out? What can I do instead? If that technology is so great, so this is what I say to my innovator friends who say, well, I've got the best technology in the world. I'm like, if your technology is so great, why don't you use it, save all the money, and keep it? Like, for example, there are a lot of authors and et cetera that tell you they can make you billions of dollars if only you bought their book. Well, why are you writing a book? Go make the billions of dollars doing what you're doing, right? So now that doesn't apply to everybody, but that's one way of thinking about technology is, if you're so great at this technology, build it, offer it for nothing to your customers, wrap a service around it, and then sit back and relax because all the money is going to be flowing in because your technology is so great.
Yeah, right on. That's good. So one last thing, and the last question I'll throw at you, kind of flip it. So if we're talking it all about, and you're always thinking about this from the innovator standpoint, it sounds like, flip it and think about it from the doctor standpoint, or the practice administrator standpoint, and how do they, amidst all of this, like, how can they be a little bit more proactive? And rather than sitting back and waiting for some, white knight innovator to come in and piece all of this stuff together and present them with a solution, how can they kind of do that part? How can they align incentives and align parties, or have you thought about it from that standpoint at all?
I have thought about it from that standpoint. And really, when you look at it, physicians, more so surgeons probably are very accustomed to doing this. Like many of the tools that surgeons use in operating rooms were designed and built by surgeons themselves. They came up with a cool idea. They shared that with, other companies, and they, of course, will partner up to build it. But that happens less at the specialty and the PCP, the primary care area. One, because they're so busy and the tooling is less important to them than their mind, right? It's a cognitive function. What you're doing day in and day out is thinking about things, whereas a surgeon has to use their hands, and so the tooling matters. But there are a lot of smart docs who are getting together and saying, hey, there's 5 or 10 or 20 of us that need this thing. Let's go work on it, and then offer it for sale to tools vendors, whether it's EHR vendors, et cetera. In fact, there's actually several conferences during the year that occur for physicians who are trying to build tools and technologies by using what they know as far as medical practice is concerned, teaming up then with companies that will help them either fund their projects or move this along. So the good news is this is happening, and the faster payment reform happens, the faster this happens as well. But the good news is you don't have to wait. There are many, both conferences as well as groups that are taking physicians' ideas as their cornerstone building blocks and then adding on top of it the health IT in other areas. So it's a great question. Unfortunately, many doctors are, of course, during the day saving lives and doing clinical work, so they don't have time to think through all of that. But the medium-sized groups, the one where enough doctors are there in the group, 1 or 2 of them can become the IT specialist, the workflow specialist, and make that happen.
Got it. Awesome. And then I know I said that was the last question, but I thought of one I wanted to throw at you during the chat there. Our 3 questions today. The first one was, what incentives have yielded unexpected results? But the second, which got a lot of traffic, as you might expect, the second question was, which incentives, we really were talking top-down incentives, which incentives have been successful? And we had a lot of crickets, and I didn't want to leave it like that. We did pull up eventually. We said e-prescribing has been a good example insofar as its adoption. It's been effective and accomplished its goal. And from going back weeks, it is a good example of us accomplishing successfully interop in healthcare because we had a very specific use case for it. Outside of that, though, there wasn't any success stories. So I wanted to see from your perspective, have there been any, or can you think of any top-down incentive plays that have gone well and have achieved their goal and have been positive for the market?
Well, I think arguably the biggest incentive program was the Meaningful Use program, and that had the intended effect of ensuring digital technologies were introduced in areas where they weren't available before. So that I think made its goal. It has a whole bunch of side problems and third-party issues that it created. I like the example of the MIPS program, the MIPA program, the medication one. So, e-prescribing, medication management, et cetera, has been a real good one. Payers have been using general incentive-based programs quite, in some cases, effectively by tying in HRAs, the risk assessments, and then offering, based on the risks that were there, offering specific incentives through digital technologies and others that I think have been to some extent reasonably successful, to some extent largely successful, depending on which particular payer you're talking about. Then very recently, we've seen a number of incentives around both accountable care organizations as well as just shared savings programs doing remote management, remote care. That has spun up a number of technologies that have been fairly successful. And lastly, I would say telemedicine, which has been around for decades, we're now seeing that with the proper incentives, and I give the example of Mercy Healthcare. Mercy out in St. Louis actually has an entire building in which there are bunches of nurses and doctors, but no patients come to that building. It's all remote management. But the incentives that they've started working with as far as, and Mercy is big, so they can pull this off, but I think others will as well. They've started working with payers to say, start to reimburse either a smaller amount or about the same amount for remote medicine, and it will actually help either maintain or reduce utilization. So the good news is that incentives do work. The bad news is they have to be well understood. They have to be defined very, very precisely. And we have to make sure that we look at incentives in a full stack way, not just what can I incent the patient to do, but what can I incent the system to do on behalf of the patient. And when thought through like that, the big boys like, your Optums and Humanas and those guys, they do a pretty good job, I think, with patients tying it to payers, but they don't do such a good job by tying them all together with patients and family caregivers and the care providers together. That's what I'm excited about over the next few years, is that some of this payment reform will cause new kinds of incentives to come out, which will work. But there have been plenty of incentives that have worked over the last 10 years or so as well. Good.
All right. So that was my list of questions for you. We're sitting at about 10 after 1 here. If you want to, we can see if anyone else has any questions or wants to jump in here, or we can break early. What do you think?
Yeah, one thing I'd like to cover is next week I'll be at HX Refactored on Tuesday and Wednesday. HXRefactored.com or aptly named HXR is our annual conference. It's the Health 2.0 guys who focus on design and developers. So the innovator side of this, where how do I build something, how do I connect to something, et cetera, is really good from that perspective. So I'll be talking about this little equation here that I've created. It basically says P of X equals U of X plus DX squared plus IX. P of X is the patient experience, and if you add that to pharmacy, provider, payer, and family with acute PH at the end, is equal to the user experience that we create, along with the developer experience and the data experience, plus the integration experience. So when we look at this in a full stack way, if we're saying that we want to affect a patient's life or affect a provider's ability to do their job or affect a payer's ability to do their job, we've got to think through the user experience, which is what's going to be covered at the conference. About half the conference is going to be about design, UX, etc. But the thing that I'm going to talk mostly about is the second two, which is DX squared. What is your data experience? How do you get data in and out of the system? What is your developer experience? What are your APIs and other things that are going to let other developers do the things that you lacked in your system? And lastly, IX is how are you integrating with workflows and context? Often you hear content is king, but context is often seen as queen, which is just as important and very, very enlightening as we start to think about integrations, as we start to think about data being available. How do we turn that data, connect with more developers, allow integrations to happen so that once we finish a product and install it inside a hospital or a payer or a provider organization, that it grows in value simply because we thought through the data experience, the developer experience, the integration experience, and the user experience. So if you guys are interested in that, I look forward to seeing you in Boston next week. And then I'll be in Atlanta on Wednesday and Thursday for the Healthcare IT Marketing and PR Conference. That's where if you've built something and now you're trying to market it and you're wondering how to make that happen, check that out. So that's at hitmc.com, and HXR is hxrefactored.com.
Gotcha. Yeah, and I did get to go to HX Refactored last year. I got to see you talk there, which was great. That was, I'd say, out of all the shows that I've been to, the best experience that I had. Honestly, it was. I think it's 2 days, so it's not incredibly long, which is nice. But what I really liked about it was, I have a developer background, so going in there and getting all of the UX conversation, I found incredibly valuable. And I like that it was it's a very pragmatic conference too. So there was there's people talking about what they're doing. Like right now, I'm solving this problem with this technique, and it's like it's very real time. It's like things that are actually happening. It's less, kind of silver bullety kind of. That's a bad way to put it, but it's less kind of dream scenarios. It's let's talking about like what we want to accomplish in 10 years. It's like I did this yesterday. I've been doing this for the last 6 months, and here's how I'm doing it. So I really enjoyed that. And what was interesting about it, again, from the UX side of the thing was it was really the whole experience. It wasn't just about, these interactions with the software or with computers or with whatever. It was about everything from, the soundscape of the hospital to the, to the way that the bills were presented to, they really came at it from all angles. And I took away a lot from that show that I never would have expected. The soundscape thing.
It's one of my favorite events of the year as well. I speak at a number of them, and I like this one because of exactly what you said. Very action-oriented. What can I do with that information today? And a bunch of techies. So the good news is that the designers come to learn about the opposite side. How do I develop? How do I integrate? What's the data look like? And then the developers come to learn, well, how do I design this thing to improve user experience and user interfaces, et cetera? I'm looking forward to I'll be leading a talk on cloud computing as well as on DevOps. And so on the design side, I'm looking forward to seeing if anybody's going to be talking about conversational UIs, message-oriented UIs, the new chatbots and things like that we're seeing in other industries. IoT, we'll cover that a little bit as well. So yeah, hopefully if anybody's in Boston or willing to fly out, definitely join us on Tuesday and Wednesday. And if you're in Atlanta, look us up on Wednesday and Thursday at hitmc.com.
Yeah, the HitMC conference sounds really interesting too. That's a newer one, right? You guys have been doing that for 2 years, 3 years?
That's right. This is our third year. And we didn't know if it would survive, but John Len, who runs his healthcare scene empire, leads that. And I support him as a co-chair and helping moderate a number of the stuff. We also give out, my company, Netspective, gives out annual awards, which will be coming out on Thursday or Friday. For the healthcare IT marketer of the year, healthcare IT campaign of the year. So we'll be I'll be presenting those awards at the conference as well. But yeah, it's a great conference. If you think you've already got the product market fit well done and your product is ready and you just want to market it, then it's a good conference. Gotcha.
And over the 3 years, I assume has it been growing? Has the attendance been up each year, or how's that looking for you?
It has, absolutely. Attendance has been growing year over year, and we're just getting larger and larger. And the problems are getting worse and worse, right? There's more competitors in almost every category. Getting those competitors to be able to delineate and differentiate themselves has been tough. So it's one of the few conferences where marketers and people on the biz dev side can come and just learn how to market. Instead of having to spend all their time doing the marketing, this is a place where they can actually learn how to market.
Gotcha. And sorry, go ahead.
From their peers is what I'm saying.
Does it tend to focus more on B2B type stuff, or with the rise of the patient consumer? Are you starting to see some more of that coming into the conversation as well?
Most of it, probably 80%, is B2B, but it's been growing. So I would say the first year we had maybe 5 or 10%. Now we have about 20% discussions around how to directly target patients. But mostly it's B2B rather than, there's very little actually in healthcare that's B2C. It's always B2B2C, right? It's business to business, which then goes to the consumer. So in that intermediation, we have B2B to B to C, and then we have B2B to C, and then B2C, not that common. Gotcha.
And since we're on the topic of these types of shows, I know last week you were in Texas, am I right, for the Health Effect?
That's right.
That one sounded pretty interesting to me too. You want to give an overview for everybody of what that's about?
Yeah, so Health Impact is a little bit different than most other events in that it's what I call no PowerPoint and no BS conference. So we invite senior leadership from hospitals, health systems, provider organizations, to come and sit with their peers and have a conversation during the day. So we normally have 2 or 3 or 4 people up on stage, and then we have an interactive conversation with the audience. So usually, 100, 200 or so people will be there, so it's fairly intimate. And we talk about things that are working, that are not working. We bring the event at each city. So we do 6 different cities around the year. And what we found is, Chicago's problems are different than Miami's problems, which are different than Houston's problem, which are different than Santa Monica. So by moving the conference around, keeping it small, very intimate in a conversation style, we talk, for example, in Texas, it turns out that within the last year, Texas rules have changed to where they're starting to pay for telemedicine. And that was a big deal. Many of the people didn't understand. They're still thinking about telemedicine as this future thing that might get paid someday. And we had actual people from the Texas Department of Health and Human Services, legislator representatives from legislators. They're talking about what is possible, what's not possible. So again, just removing all the BS, getting beyond the taglines and the hand waving as I'm waving my hands right now, and really talking about practical stuff. What can I do today? How do I solve my problems? What can I get paid for? What's not going to get paid for? What should we tell the innovators? So we had innovators up on stage to say, why are you doing things this way instead of that way? And it's very helpful, I think, to have those clean conversations as if we were talking around a dinner table, rather than these formal PowerPoints and presentations where one person is trying to teach someone else. So we assume at Health Impact, everyone is already smart. They already know what they're doing. They're just trying to find out how to best do their job for the following week and months coming up.
Awesome. Yeah, that sounds great. Sounds like it's got a similar kind of flow and feel to the HXR thing that we were talking about at the opening there. Very nice. Mm-hmm. Okay, cool. Anything else that you wanted to throw out there before we wrap for today? No,
I think we're ready to roll. Thanks for doing this. These are great every week. Follow them religiously, and I'm glad to participate whenever you want to have me on.
Yeah, absolutely. I'm glad to have you here. This is great. And I'd say the takeaway for everybody is don't be a lazy innovator. Don't be somebody else to solve the problems for you. Make your own alignment. I like that. All right, great. Well, thanks, Shahid, and thanks to everybody for coming around. And we hope to see you next week. Let us know if you got any ideas for the show, or if you wanna get involved in some way. We're happy to have you. Great. Thank you.